Andrew. Can I go straight over to Becky, who wanted to ask some supplementary questions?
Thanks, Chair. So just one, actually, Marion, around the trend of your data. So you've talked about the fact that it's the numbers are coming down, which is great, but also the relative difference, as unfortunately maternal mortality for white women is going up. And I just wondered, have you modelled the trend of where you see the numbers going? So in other words, have you done any analysis that says in 5 years, 10 years time, you expect it to have decreased by X%? And in that modelling, have you worked various different scenarios as to what might bring that trend down further?
Simple answer is no.
No. Okay.
I don't want to make excuses, but it is very difficult to do nuanced modelling with maternal mortality figures. And one of the things that you might let me say later is that I think we really need nuanced data on maternal morbidity, and we don't have it.
If it's okay, Chair, I mean, am I all right just to ask about nuanced modelling data?
Yeah, and then go on to your own question.
Fine.
Right.
So, Marion, please talk about that. It would be good to hear about the research that needs to be done still. That would be really helpful.
So, for example, we as Embrace, we have a responsibility for monitoring baby deaths as well as maternal deaths. Baby deaths, sadly, are more common, but that means that we've been able to develop what we describe as a real-time data monitoring tool. So every hospital has a live data viewer where they can see every death occurring in their hospital. They can see trends, they can look at different groups so that they've got a way of immediately responding to changes in the patterns, but also an immediate way to see the impact of any interventions, any changes they make, any training we've talked about. We don't have anything like that for maternal morbidity. That's what I would love to do, because then we've got a way of evaluating our actions. So the question earlier was, what does good look like? We don't know, because we often don't evaluate what we do because we've got no way of doing that easily and quickly. If we've got a data system, and we've got so many opportunities with data, we can evaluate what we can do. We can spread the good across the country.
And Marion, and I'll move on in a second, but why hasn't this data on maternal morbidity and mortality been collected already?
I think there's, understandably, do we want our staff to be spending time collecting data when they could be caring for patients? So I think we're now at a time of opportunity when our electronic systems are so advanced that we can do it without that additional staff burden. So I think it's a window of opportunity now to do it.
Right, that's really helpful, thank you. So, Sola and Shanthi, I'd like to move on to talking about an issue that Tanuka raised in the first panel around the health of black women entering pregnancy compared to other ethnic groups. So, thinking about pre-existing conditions, thinking about how the health of black women compares to other ethnic groups in the population, and once black women are pregnant with these pre-existing conditions, how well those health needs are met. So, Shanthi, start with you.
I completely agree that we need to have greater awareness of how different conditions manifest in different bodies, and that's a really clear finding from the Birthrights 2022 report, that you just don't receive training on how to recognise sepsis or jaundice in different bodies. However, I really want to emphasise that there is nothing wrong with our bodies as black and brown women and birthing people that can explain away the disparities that we're seeing in maternal outcomes and experiences. And there's a kind of very concerning meta-narrative going on around pregnancies and bodies being increasingly complex, clinically complex, and I think there has been evidence provided by Sue Down and others to show that the increasing rates of interventions aren't matched by the risk profile changing at the same rate. So I want us to be really cautious around this kind of angle of bodies and lifestyles being the problem. I think you will have seen from various sources of evidence that this is about racism in all its forms, and I think we also need to contextualise this within the fact that the maternity system is broken for everyone. You've seen so many reports into the state of maternity care in different hospitals and trusts, and women, whatever their background, are having a horrendous time for the most part. And what we can see at the heart of all of these inquiries and reports is that women are not being listened to. Their voices are not being listened to. The decisions they're making about their bodies and care are not being respected. Fundamentally, we have a right to decide what happens to our bodies and our care, and we have the right to be given unbiased information to be able to make that right, for that information to be accessible, and to not be coerced into practices. And when that system is bad for everyone, what we're seeing is it's disproportionately bad for Black, Brown, and other marginalised communities. And if we understand that the fundamental problem is about a misunderstanding of rights, like there is no understanding of rights from the front line to the regulatory services, right? Like that we have these rights is just not understood. Then the way the system is being designed isn't with our rights in mind. So it isn't enabling person-centered care. It's not enabling us to make informed decisions about our bodies and our care. And so when you've got this meta-narrative of clinically complex, increasing risk, the response is through that lens, and we're seeing more strict guidelines and pathways as to what needs to happen for different communities or demographic groups, which just instantly locks out whole communities from being able to make informed decisions about their care. It's if you come from this community, you're suddenly on this pathway. So, for example, in our recent home birth report, we're seeing Black women being denied access to home birth services because of their ethnicity or demographic group, right? And so in these circumstances, we're seeing people are preferring to opt for unassisted birth, where there is no medical care or intervention, not out of an empowered decision to free birth, but because they feel like there is no other option, because the service is not listening to their voices, is not providing them with a safe space where they are getting personalised discussions about the risks that they're facing. And so within that context, and understanding that this is about racism, we need to understand that this is about racism, yes, at a relational level. Yes, there's huge issues with healthcare professionals, microaggressions, racist stereotyping, as Chineke described, and not racism at a relational level, but they are also operating within a system where they are not enabled or empowered or supported to give person-centered care. And so the problems are also institutional, they're also systemic, and they're also structural, and therefore the solutions need to be at all of those levels. And it feels to me, from looking at the response of the different NHS trusts, but also of the NHS as a whole, I'm on the equity and equality steering group, I think, for the NHS, and the Stakeholder Council, that it almost feels easier for the NHS in the face of these huge, big problems to reach for the kind of cultural interventions, anti-racism training for staff and leadership, and clinical interventions and pathways. But I think we really need to be looking at it in terms of if we're really wanting to affect meaningful change for Black, Brown, women and other marginalised communities, we need to be looking at structural levels. So at Birthrights, we're calling for new legislation. We think there should be a new Safe Maternity Care Act that makes clear how human rights and other law applies to maternity care, to make sure that everyone from the front line to the managers, commissioners, regulators understand and ensure that safety, accountability, freedom of choice and equity are at the heart of everything to do with maternity care. We We need to end NHS charging, which is limiting access for women and birthing people, whether they would face charging or not, particularly marginalised, vulnerable women and birthing people. We need to be preventing the dismantling of core maternity services. You know, the government is talking about more NHS community-based care, and yet we're seeing the rolling back and the prevention of home birth and community-based services. And I think to this point of good practice that was talked about earlier, there are teams within the NHS or individuals who are really trying to provide person-centred care, and the institution is preventing that. And sorry, I know I'm talking, but I just want to
no, it's fine, and it's okay. What you're saying, no, absolutely, it's really valuable. So I'm going to bring in Sonna, and it's really interesting what you're saying, because I think listening to you, I can hear I love the person-centred care, regardless of what you look like, where you're from, is absolutely the gold standard. And just when you were talking about other marginalised communities, I just wondered if you wanted to talk about socioeconomic disadvantage and, you know, where people are starting from in terms of their ability to access good nutrition, their ability to access good health services, because we know disproportionately more people from minority ethnic communities are socioeconomically disadvantaged. So I don't know if, Sonna, you wanted to talk about that at all.
Yeah, I guess from our work and our experience, there's quite a lot of like anecdotal evidence that show, or that tells me, that often the response from healthcare professionals to some of those existing conditions looks really different for black women than it does for others. So, for example, if a black woman is starting her pregnancy journey and is diabetic or has a high BMI, I know that her midwife is much less likely to offer interventions around movement and good nutrition, and much more likely to rush to medication or more clinical intervention.
Why is that, Sonna?
You'd have to ask midwives. I mean, I have my suspicions. Suspicions, but I think that's probably a question for healthcare professionals. I think we see it in preeclampsia and measuring blood pressure. Quite often going into a NHS maternity environment can be quite a stressful time for a black woman. So if her blood pressure is reading consistently higher when she's at appointments, having the I guess being able to look at that situation a bit more critically and maybe take that woman's blood pressure in a home environment or in a community where she feels a bit more at ease can make a massive difference to how her preeclampsia is recognised and managed throughout her pregnancy journey. And I feel like from my white friends and my white neighbours, those kind of that more softer first step kind of clinical care is offered much more frequently and encouragingly than it is to people within black communities.
That's really interesting. And do you have any thoughts? I mean, Shanti obviously has mentioned person-centred care, but do you have any thoughts about how we can bridge that inequity, that sort of clearly perhaps sort of a different style of approach based on the colour of your skin? Do you have any thoughts about how that might be improved or addressed?
I think having confident, honest, thoughtful conversations about the ways race and racism show up in all of their different dimensions across maternity care is probably the first step. Even in my own experiences, I remember my first connection with maternity was my booking appointment, which is typical, where you're typically weighed and height and your BMI worked out. BMI is flawed. I was told at the start of each of my pregnancies I was overweight. As a black woman, I feel quite confident that I'm not overweight. I also know that if I'm being told I'm underweight and BMI is the marker for that, there is probably a whole heap of black women that are underweight for black women that's not being flagged, and going through pregnancy underweight is very dangerous. So there's being able to think critically about all of these kind of touch points that happen that disproportionately negatively affect black women is the first thing that one of the first things that needs to happen.
That's so helpful, Sana. And BMI, I think, is an interesting discussion, and it comes up obviously with the National Child Measurement Programme as well. It's a really interesting discussion in terms of different body sizes. So thank you for bringing that up. Thank you, Chair.
Thank you, Becky. Can I go straight